to take this opportunity to welcome our past immediate chairman, my guiding chairman, Dr. Narayan Hepsur, secretary, of course, our Dr. Chandrasekhar Tumkur, and today's moderators, of course, Dr. S.C. Metgud, as well as Dr. Harsha, all the head of the departments, and of course, the viewers, executive committee members, HODs, postgraduates, and all of you, those who are able to make it. And I welcome all of you. And I think without wasting much time, I'll hand over this to now Dr. Medgood and Dr. Harsha. Please take over and proceed. Thank you.
Thank you, sir.
Thank you. Good evening, everybody. At the outset, I would like to thank our association for giving us this opportunity to moderate this session. I have been given the very pleasant task of introducing Dr. Himagirish K Rao. Actually, he does not require any much introduction to all of us, but since there are some young trainee surgeons, postgraduates who have joined, for their sake, I'll just go through the brief introduction of Dr. Himagirish K Rao. He is presently working as Professor of Surgery in CDSIMER, that is the Dayanand Sagar Institute of Medical Sciences, Karnataka. He's a very well-known consultant endocrine and breast surgeon practicing at Manipal Hospitals, Excel Care Hospital in South Bangalore. Dr. Himagirish K Rao did his MBBS from Bangalore Medical College in the year 2001. Then after that, he got his MS degree from Stanley Medical College in 2006. And then he completed his MCH in endocrine surgery with a gold medal in the year 2013. And then he worked as a chief endocrine surgeon in St. John's Hospital between 2017 to 2024. He has got many publications in index journals which have a very high citation rate. And he's also a member of the Hypothyroid Guidelines Society, that is the Indian Thyroid Society. He's the member of Task Force for Thyroid Cancer Guidelines. He's also on the editorial board of Indian Journal of Surgery. He has been invited at national and international conferences, even at the KSC level and even at the national level. He's very active in the academic sessions of our organization. And his hobbies include photography, quiz, and then is very much involved into Carnatic music. Presently, he's also serving as the Joint Secretary of Indian Thyroid Society. We are very lucky to have with us a very well-known and eminent endocrine surgeon who will be telling us the story of thyroid surgery over the time, that is from slow days to Storz age. And personally also, Dr. Himagirish Rao is a close personal friend. So it's my privilege to introduce you, sir, and I welcome you to proceed with your address. Thank you.
Good evening, everybody. First of all, Dr. Harsha, thank you for the very kind introduction. You've been kinder than necessary. My salutations to Rajgopal Shenoy, sir. It is my pride that I have been Rajgopal Shenoy sir's student. Might not be in person, but certainly his book was a very popular book for us. Of course, we had Bailey and Love, and our examiners would always advise us to read Bailey and Love. But when the exams are near, you cannot read a 2,500 page book. We need a ready reckoner, or we need something that distills it and makes it very easy for us. And Manipal Manual was our Bible at that time. And I am absolutely thrilled to say that Rajgopal Shenoy sir has been very instrumental in my passing my first surgery exam, that is the MBBS exam in 2000. Thank you very much, sir. The Secretary, Dr. Sarvesha Rajars from Mysore. It was a real pleasure when I got a call from him and he asked me to speak here in this August forum. Please excuse the pun. It's always a pleasure to talk about surgery, and more so in on the Karnataka stage. Thank you very much for the invitation. My salutations and greetings to the other senior members here, many of whom I know on a personal level. Many of them my very good friends. I thank you all for having come online, spared your time, and to listen to my drawl over the next half an hour or so. So when Dr. Sarvesh called me and he said my brief was to talk to Karnataka surgeons for about 30 to 40 minutes, I was thinking what to tell them. There's nothing that a practicing surgeon needs to know anew about thyroid surgery as such, be it the present evidence or be it the way to do it. Many of you know it much better than us. So I thought a good way to engage everybody was to sort of try and go over the story of thyroidectomy and how it evolved over time. ಇನ್ನೊಂದ್ಸತಿ ಥೈರಾಯ್ಡೆಕ್ಟಮಿ ಮಾಡಿದ ಜರ್ನಿ, ಅದರ ಪ್ರಯಾಣನ ಅದ್ರ ಬಗ್ಗೆ ಒಂದು ಮೆಲುಕು ಹಾಕೋಣ ಅಂತ ಒಂದು ಅಂದ್ಕೊಂಡೆ. ಸೊ ದಟ್ ಈಸ್ ವೈ ದಿ ಟಾಪಿಕ್ ಟುಡೇ. ಸೊ ದ್ಯಾಟ್ is a picture of the Ganga, and no prizes for guessing the city. That is Varanasi. Varanasi, I like to call it the forever city, and Ganga, of course, is in so many ways, it's the mother of our country. Why this picture? Well, today we have our subspecialties like endocrine surgery or oncology or gastroenterology and everything, but ultimately all of us will have to go back to the mainstream, that is general surgery. So if general surgery is to the discipline of surgery as what river Ganga is to the country of India and its river basins. So always it's natural that we sort of pledge allegiance to the vast stream and the superset of ours, that is surgery. So having digressed enough, let us get to the story of how thyroid evolved over time. So Anadi Kaladalli, Nama Charaka Sushrutaru, they were the foremost physicians for the world, because I sincerely believe that our society predated, or at best was a contemporary of the oldest human civilizations in the world. So Charaka Samhitadalli ide Galagandaha Pradhanascha Nityam Nadi Jalashraya. Galaganda ಅನ್ನೋದು ಥೈರಾಯ್ಡ್ಗೆ, that was the term. The thyroid or goiterಗೆ it was the term. Goiter was called Galaganda in Sanskrit. And he says that goiter is prevalent among those who are the dwellers of the banks of the rivers. Sushruta says, Gale mamsapidakaha syuhu galaganda iti smrutaha. So a flesh or a lump that causes considerable discomfort to the person, it can also be called galaganda. So goiter as an entity was known to our physicians back then, when we did not know how to measure time. Coming forward, ancient Chinese texts also have evidence of administration of burnt seaweed and sponges to treat goiter. Probably they knew that seaweed and sponges do contain iodine, and that iodine has something to do with thyroid and goiter. Coming forward, Paul of Aegina, a classical Byzantine doctor, he refers to struma and its operation. It is not clear whether the struma that he refers to is the same struma that we know as goiter. Little further, around the end of the first millennium, Albucasis, a Moorish physician, his is the first record of thyroid surgery available in the world. So he removed a large goiter under sedation with opium. He used simple ligatures along with hot cautery irons, and the patient sat with a bag tied around his neck to collect the blood from the wound. Must have been quite a grotesque scene this to watch. And then maybe 100-150 years further, there was a leading surgical center in Italy which was developing. It was called the Salerno School. Roger Frugardi was one of the foremost teachers and surgeons who came out of that school. He performed thyroidectomy using cetons, hot irons, ligaments, and caustic powders. He even wrote a treatise, Practica Chirurgiae, which became the principal manual for surgery probably 700, 800 years ago. And then, after all this initial promise, it was as though surgery and thyroid surgery entered into a dark tunnel. The church started meddling its affairs into health and healthcare. It started to control university legislation. Progress started to wane. It discouraged medical activity, especially surgery, amongst educated people and clerics. Libraries shunned books on surgical works, and it was not thought to be a very respectable vocation to perform surgery. And hence, doctors started to avoid taking up surgery. Probably a figment of this is that when we go to the Western societies today, particularly England and the British Isles, the medical people are all called doctors, but the surgeons are called Mr. And when we just pointed this out to them, they said, no, Mr. it's a title of respect. Mr. is somewhat more respectable than a doctor. This is what they say. ನಮಗೆ ಸಮಾಧಾನ ಪಡಿಸಕ್ಕೆ ನಮಗೆ ಸಂತೋಷ ಪಡಿಸಕ್ಕೆ ಹೇಳ್ತಾರೆ. But we all know the letters DR, they do carry a kind of a pantheon in our society today. So surgery was disjointed from medicine, and it began to be controlled by uneducated people, the so-called barbers. And indeed, the Royal College of Barber Surgeons was what it started off as. These barbers set broken bones, they drained abscesses, did bloodlettings, which were all considered part of medical care in those days. So after this, there was a revival, there was a slow revival. Whatever goes down has to come up. It can't stay down all the way. So there were a couple of people, G. de Chauliac, Henri de Mondeville, or Guido, or Bonitas Lanfranchi, France and Italy. These were the epicenters of the revival of sciences, or the Renaissance. So teachings of Albucasis and Roger Frugadi, they were sought again. However, there was no reference to thyroid surgeries performed by these people. And then we come to 1511, the 16th century. Leonardo da Vinci, we all know him, and we all know the Vitruvian Man as his most famous painting. And his first recorded anatomical picture of the thyroid gland is there in the literature. However, the exact function of the gland was not known to him. He simply presumed that it was flesh that would fill the interval by the deficit of muscles in the neck, thereby shielding the trachea from the sternum or the skin in front. So he thought it was literally and figuratively a shield. This aspect is something that has sort of been jettisoned over time. We simply think thyroid is shield-like because of the reference of the shape, the similarity of the shape, and not the function. And then we come to the 1700s and 1800s. Pierre-Joseph Dasson, Paris, he was the first one to perform a partial thyroidectomy. And then there were many other people like Dupuytren, William Blizzard, or Henry Earle, who followed him closely. Heusser is said to have performed 35 thyroidectomies with only one death. But given that there was quite a primitive understanding of the physiology of bleeding or thyroid, we would have to say that this is beginner's luck. And then there was Toubigen in Belgium. He was the first surgeon to have separated the isthmus from the gland. And he also had a very impressive mortality rate with regards to surgical procedures. Still, thyroidectomy was in the doldrums. The case was believed to have a 40% mortality. So 4 out of every 10 people who underwent thyroidectomy would ultimately succumb, be it due to hemorrhage or due to choking or gangrene and infection or an air embolism, whatever it was. Even the most skilled were jittery and they avoided operating on goiters. And many people even famously went on record dismissing thyroidectomy. Robert Liston said, it's a proceeding by no means to be thought of after performing 5 thyroidectomies. Samuel Gross went further. Can the thyroid in the state of enlargement be removed? Emphatically, experience answers no. Should the surgeon be so foolhardy to undertake it, Every stroke of the knife will be followed by a torrent of blood, and lucky would be the person if his victim lived long enough for him to finish his horrid butchery. No honest and sensible surgeon would ever engage it. The French Academy of Medicine also banned thyroid operations in 1850. So this was sort of the second challenge after the church, and it was about the early 1800s when all this was happening. So how did it get out of it? So anesthesia, infection prophylaxis, and improvements in understanding and the technique of hemostasis. These were the three factors which hauled thyroid back up. Oliver Wendell Holmes coined the term anesthesia. Moulton demonstrated the use of ether in 1846, and we all celebrate 25th of October as Ether Day. Certainly our anesthesia friends do so, and we join with them. We join them in our cups of coffee and cakes in the theater. 3 years later, Nikolai Peringov performed a successful thyroidectomy using ether anesthesia in St. Petersburg, Russia. Infection prophylaxis, we all know Joseph Lister and the use of carbolic acid. Gustav Neubauer was the first person to popularize and regularize the use of cap and gowns in the OT. Steam sterilization of instruments started, it came into vogue. And then we have the Spencer-Wells forceps, which is the medium artery forceps, the curved medium artery forceps. The first effective hemostatic forceps was designed by them. This brings us to the Theodores, Cocker, and Billroth. And not only them, this pantheon of pioneers, the Magnificent Seven, as many of us call it. Theodore Billroth, Theodore Cocker, William Halsted, Charles Mayo, George Cryle, Frank Leahy, and Thomas Dunhill. So what all did Billroth do for us? As with laryngectomy, esophagectomy, and gastrectomy, the story of modern thyroidectomy starts with Theodore Billroth. He was a behemoth in the surgical scene in the 19th century. He took his first university chair in Zurich in the year 1860 at the tender age of 31. He instituted surgery for compressive symptoms, but initially became disheartened by 8 of his 20 patients expiring. So he suspended such endeavor. 6 years later, he re-established himself across the border in Vienna, and he resolved to try again. And then he applied the principles of hemostasis, asepsis, and then his mortality rate dropped to single digits. And he was well on his way to becoming the most practiced thyroid surgeon worldwide at that time. Of course, this was the time when, for the Western world, their world was across the pond, and we were sort of oblivious to what was going on across Europe and the Americas. And we might have had our own advancements in our fields of medicine. Sadly, it lies alien to us, it lies hidden from us, or may even be destroyed. Nonetheless, Theodore Billroth was not just an expert surgeon, but he was a masterful scholar too. One of his assistants, Wulfler, was the first to describe tetany after thyroid surgery, as well as highlight the danger to recurrent laryngeal nerves and voice. Ivar Strandstrom in 1880 identified the parathyroids. He named it the glandulae parathyroideae after their position by the side of the thyroids. Eiselberg, another of his students, became the first to experiment with transplantation of thyroid and parathyroid tissues. So this parathyroid autotransplantation, which I personally thought, I was exposed to parathyroid transplantation after I got into my MCH, probably 15 years ago. And then when I was preparing for this lecture, I found out that this autotransplantation is not 15, but 150 years old. Quite humbling. So Gley in 1891 demonstrated the link between post-op tetany and parathyroid excision or disruption. Jan Mikulix, he was the proponent of subtotal resection, allowing residual functioning thyroid tissue and to allay emerging problems of removed thyroid function. However, one student who truly took the baton from Billroth for an astonishing run was the other Theodore, Emil Theodor Cocker, whom we now know as the father of thyroid surgery. That is Dr. Cocker. He accepted his own university chair in Bern in 1872. So we have two Swiss Theodores here, Theodore Billroth and Theodore Cocker. So like his namesake and mentor, he found himself surrounded by endemic goiter, which is no surprise, Switzerland being a landlocked country of mountains. At that time, Bill Roth had suspended thyroid surgery, but Cocker remained determined. Scrupulous asepsis with obsessive hemostasis, and Cocker's operative mortality rate plummeted to less than 1%. In the same year, he also described the transverse collar crease incision, which still bears his name today. Reviewing his life's work, he detailed a mortality rate of 0.5% for close to 5,000 thyroid operations that he did in his time. Bern became the global capital for thyroid surgery, attracting observers from far and wide. When he started thyroid surgery, Cocker initially performed total thyroidectomy. In the follow-up, however, these patients were found to be physically sluggish and mentally slow. In describing an 11-year-old patient postoperatively, Cocker noted that she has become peevish and dull and will not work except under compulsion, whereas formerly she was a spirited and joyous creature. Across the channel, a London contemporary had postulated that a cretinoid condition in postmenopausal women was prevalent, with the women having dry skin, coarse features, slothful demeanor, and mental retardation. Cocker recognized this cretinoid state in his postoperative patients, and he considered it as a result of total thyroidectomy. He described it as cachexia strumipriva, strumi referring to the goiter. So after this, he started limiting his practice to one-sided lobectomy, saving total resection for intractable compression or cancer. In 1883, Seaman, another British physician, postulated that the demise of thyroid activity was the root cause of Gull's cretinism or Cocker's cachexia and myxedema. That same year, Cocker concurred, publishing the results of total thyroidectomy, thus finally prescribing an essential function to the gland. As well as encountering myxedema, he encountered the striking malady of exophthalmic goiter, as described by Graves preoperatively. While his contemporaries would shy away from such thyrotoxic patients, Cocker designed staged surgery for them. A first stage of ligation of the vessels, followed by a second stage of one-sided lobectomy. If the patient was unlucky enough to have a recurrence, then a third stage would be considered to reduce the size of the remaining lobe, but ensuring residual tissue to offset myxedema. Cocker's mortality rate for such cases was only 4.5%, which was extraordinary for that time. However, today we know that we have a very easy to take, a very inexpensive replacement. We know what the thyroid produces. We know that a replacement hormone is available in a size that is slightly more than a grain of lentil, and that it's quite easy for us to manage the hypothyroidism or the postoperative stage where the patients are thyroid dependent. Back then, these giants did not have the luxury that we have today. So Cocker stands colossal over the field of thyroid surgery. No wonder that he is the first surgeon to ever receive the Nobel Prize in Physiology in 1909 to honor his life's work in trying to understand thyroid disease. By the end of Cocker's reign, thyroid surgery was neither foolhardy nor deserving of rebuke and condemnation. Operative mortality was at last reasonable, and complications of myxedema, tetany, and vocal fold palsy were medically understood and surgically avoided. Of course, while Cocker was applying his trade in Europe, there were a lot of people alongside him in Europe as well as across the Atlantic who did help to achieve the last sentence that I just read out. Brings us to William Halsted. So takes us across the Atlantic to the Americas. So thyrotoxicosis was a big hurdle still. And in later years of his American training, William Halsted toured the celebrated clinics of Europe. On observing both Bill Roth and Cocker, Halsted became intrigued by this gland and its surgery. It was Halsted who noted that while Cocker was plagued by postoperative myxedema, his patients rarely had problems with tetany. Bill Roth, however, experienced the contrary. So Bill Roth's patients, while they were spared of hypocalcemia or nerve problems, they had a lot of mixed edema. Cocker was meticulous in tissue handling and fastidious about hemostasis, thereby entirely excising the thyroid with little damage beyond its capsule. Bill Roth, however, was less fussy about handling and hemostasis, so he was quite fast in surgery, leaving residual tissue, likely also taking out the parathyroids or at least disrupting the blood supply. And this is why the contrasting profiles of postoperative adverse effects for the two of them. On his return, he was disappointed that surgery in America was still stagnant, that asepsis and hemostasis revolutions of Europe were yet to lap the shores of the Americas. In 1889, Halsted assumed his lifelong professorship at the Johns Hopkins in Baltimore. There began his own work on thyroid surgery. He reported injection studies that demonstrated parathyroid blood supply. He showed canine postoperative tetany could be controlled with calcium salts or ingestion of parathyroid extract. He went on to verify that parathyroid transplants would avert tetany. Halsted was very protective about parathyroid glands and only performed lobectomies with obsessive parathyroid preservation. To additionally protect parathyroid blood supply, he advocated ultraligation of the thyroid arteries distal to the parathyroid branches. So contrary to what we believe to be a product of this century, this ultraligation or ligation of the thyroid branches beyond the parathyroids was quite prevalent even 100 years ago. Halsted thereby eliminated any risk of tetany in the remaining thyroid lobe needed a second surgery. For his thyrotoxic patients, Halsted followed Cocker's lead and executed staged surgery. Like Cocker, his operations were meticulous, aseptic, and bloodless. They were symptomatic, systematic, and founded on anatomy and guided by physiology throughout. Other contributions included his design of hemostats and specialized instruments that improved both efficiency and safety. To originally protect the hands of his scrub nurse, who would be his wife later, Miss Caroline Hampton, Halsted introduced the wearing of thin rubber gloves, and the byproduct was that asepsis in the theater vastly improved. His magnum opus, The Operative Story of Goiter, the author's operation, is still the chief chronicle of thyroid surgery. And in his own words, the extirpation of thyroid gland for goiter probably typifies better than any other operation the supreme triumph of the surgeon's art. Quite a journey and departure from when it was condemned and when it was forbidden to this statement, which exalts the thyroid surgery on the top of the surgical procedure heap as far as surgeon's art is concerned. Quite proud for a thyroid surgeon, for a man of Halsted's stature to have said something about a surgery that is quite dear to him. Humbling as well. So we move to Charles H. Mayo and his clinic in Minnesota. He was, I went through a monograph of these 7 people, and I thought the best way to emulate was to literally read out verbatim from the paragraphs that was written about these people. Try as I might, I can't do a better effort than them in these words. Charles H. Mayo was dramatically introduced to thyroid surgery in 1890 in the form of a stupendous goiter compromising the breathing of a burly local farmer. In view of the precarious airway, he and his brother William essentially employed a slash and grab technique during surgery. Not surprisingly, hemorrhage was heavy, but control was ultimately achieved by packing the cavity and oversewing the skin. So packing was not just done for liver, it was done for thyroid as well. The packs were removed days later, and amazingly, the patient soon returned to work on his farm. Charles remained amazed and indeed stimulated about such thyroid surgery, whereas Williams was not amused. So Charles Mayo became the thyroid surgeon at their eponymous clinic in Minnesota. Initially, he had high mortality figures, which is understandable. However, he stayed undeterred, especially as thyroid disease was thought to be medical at that time, and he was only referred severe cases for surgery as a final option. probably not too different from our scene today. With time, better surgical technique, and with earlier surgical referrals, Mayo's mortality rate fell. He moved on to tackle the feared problem of hyperthyroidism, a term which he first used. He adopted Cocker's method of stage surgery, but unlike midline split of the strap muscles, Mayo divided the muscles to amplify exposure, a technique which he first propagated, and a technique which an endocrine surgeon believes is better. Exposure is king, so whatever it takes to expose the probably the upper poles or the parts of the neck which is difficult to access, the best exposure is the best aid for surgery. Mayo had performed more than 200 surgeries. His later continued success must be credited to his medical colleague Plummer, who recognized the benefit of iodine in preoperative preparation of patients. With Plummer's preoperative input, Mayo's operative mortality rate sunk to less than 1 for thyrotoxicosis. The need for stage surgery also dived, and all in all, in his time, Mayo remained unmatched on his content for the highest number of thyroidectomies and the lowest mortality. Hence his other title, the father of American thyroid surgery. George Kreil, we all know Kreil's method of palpation where we use our thumb to palpate a solitary nodule. He was instrumental in describing postoperative thyroid storm, which he encountered in one of his patients while operating. So he was the one who advocated the thyroid steel, whereby patients of thyrotoxicosis who are anxious are told repeatedly that we are going to operate to you today, we are going to operate to you today. They're told this day after day after day. And one fine day, they're just taken to the theater. And when the patient gets sensitized, this is another wolf story, Thoda Bantu Thoda story. And then finally the thyroid gets taken out. A little personal input. Thyroid steel was one of my questions in my MS examination. And I didn't know the answer at that time. Had I read more, probably. So Frank Leahy, he was the gentleman who introduced the concept of basal metabolic rate, and he investigated it as a function of hyperthyroidism. He was instrumental in identification and preservation of the recurrent laryngeal nerve, parathyroid autotransplantation into sternomastoid muscles. These were some of the steps that were championed by Leahy. So while all this was happening between Europe and America, there was one man in the far corners down under in Sydney, Thomas Dunhill. His leg began at a time when surgeons dreaded operating on thyrotoxic and especially thyrocardiac patients. So Cocker said excision should not be undertaken when the disease is advanced. And Dunhill believed that these very patients were the indication for surgery. The problems were that postoperative thyroid storm was often fatal. Recurrence of thyrotoxicosis was a natural outcome of suboptimal excision. Physicians were unwilling to send their patients to surgery, their prevailing feeling being that thyrotoxicosis was essentially a medical issue, and only those patients who were almost no-hopers were sent to surgery. Operating on such patients who were emaciated and almost blinded, suffering fibrillating and waterlogged hearts, invariably resulted in high mortality. The doyen of British thyroid surgery at that time, Berry, also opined that surgery was worse than useless. Of course, every time we perform a thyroidectomy, we invoke Berry when we encounter Berry's ligament and the troublesome blood vessels there. So Dunhill believed that key to success was resection of the sufficient thyroid. He believed that lobectomy had no role and thus resurrected subtotal thyroidectomy as originally described by Jan Mikulicz in Poland. He started his bilateral attack on thyroid even before Cocker dared tread into this thyrocardiac territory. Over 4 years, Dunhill achieved more than 200 thyroidectomies. He achieved this with refinement of technique, which caused a vast improvement in morbidity and mortality, increasing early referrals, and this further improved his outcomes. He took his world around the world to London, America, elsewhere. There was gradual acceptance, but the credit was given to their respective people. The world took fancy to subtotal thyroidectomy over Cocker's stage surgeries. However, unfortunate for Dunhill, he was not credited with all this, and the credit went to his contemporaries in the respective continents So he is sometimes referred to as the forgotten man of thyroid surgery. However, history corrects this injustice, and for his classic work, Dunhill can stand proud as one of the magnificent 7 proponents of thyroidectomy. So while all this was happening for thyroid, there was also work on parathyroid and hypocalcemia. So various surgeons like Gley, Vassal, Billroth's pupils Jan Mikulix and Anton Wolfer, and all these people helped in developing our understanding about hypocalcemia and mitigating this problem. Jan Mikulix devised a new approach to thyroidectomy. He suggested that with preservation of the posterior aspects of both the lobes, tetany could be prevented. Anton Wolfer described tetany in detail. Halstead and Evans, again, a repeat of what I said earlier, ultraligation of thyroid arteries was to be practiced, which was ligation distal to the points of origin of the parathyroid artery branches. What about the nerves? Jan Mikulix is the pioneer of RLN preservation, preservation of the posterior aspect of the lobes and avoidance of dissection behind the thyroid. Mirror examination of the larynx paved way for diagnosis of vocal cord palsy. And I was surprised to know that the first person to actually do this was a singer and not a doctor. We come to Amelita Galli Curci, the Italian opera singer. She was unfortunate enough to have to undergo thyroidectomy for goiter. And post-operatively, she lost her USP, that is the high pitch voice. The complication that happened can now be recognized as an injury to the external branch of the superior laryngeal nerve, the EBSLN. So the cricothyroid muscle would turn paralytic. So the patient would be unable to sustain high tones. So coming to the 20th century and hence, Soderstrom in 1952 championed the FNAC for thyroid nodules. We can't fathom thyroid surgery without a cytological diagnosis today. Sonoda and Waghai first reported using ultrasound for evaluation of thyroid. So comparing the 1,000-year history of thyroid surgery, this is like just happened yesterday. This was the 1960s. Fujimoto of 67, his work on ultrasound is the most cited and the first article on ultrasound of the thyroid, his group in fact. And we all believe today that the first line of investigation as far as the thyroid is concerned is the ultrasound. The moment the patient walks into the OPD, I look at the patient, I put my finger on the neck. The next thing I do is an ultrasound. Many of us have ultrasound machines in our OPDs and we put an ultrasound probe on the patient in the same sitting. The late Elbridge in Sydney, he championed capsular dissection. It's a sad fact that we lost him recently, a couple of years ago. He was one of the living legends of thyroid surgery and we used to acknowledge and respect him a lot while he was with us. And he was very kind to share his insights in many of our meetings. So there we see the plane of capsular dissection that is anterior to the parathyroids. And we need to ligate the individual branches. There in the picture, you can see the parathyroid over there in the oval, and that is the nerve. So capsular dissection enables us to view this, enables us this view while we are performing a parathyroidectomy. This lady, incidentally, was a teacher from Jharkhand, and she was a relative of one of my postgraduates. She is very kind in consenting for her photograph to be allowed in academic presentations. The other thing that Delbridge championed was the parathyroid autotransplant. Of course, transplantation has been being done for more than 100 years, but it was he who found that the maximum size of the particle that can survive by imbibition is 1 millimeter cubed. So what he advocated was, instead of mechanically slicing or cutting the parathyroids for transplantation, he advised that we mince it into a suspension. The particles are so small that they get suspended into a yellow opaque fluid, and that can be aspirated in a syringe and injected into the belly of the muscle. We generally prefer the sternomastoid, ipsilateral sternomastoid. Sometimes it can be done in the brachioradialis as well. In fact, this was my thesis topic. I endeavored to estimate the viability of grafts after autotransplantation. So for this purpose, I used the brachioradialis muscle. So what we did was we took out this and we made a suspension of the parathyroid, and then we had saline in another syringe. So the test arm was injected with the parathyroid and the control arm was injected with saline. 4 weeks later, we took peripheral blood from the cubital veins, both the cubital veins simultaneously, and we estimated parathyroid in the veins, in the venous blood. And we considered a gradient of 1.5 to be indicative of a viable parathyroid. The closer the parathyroid to the vein, the more the parathyroid concentration in the blood. This is what we set out. This was our postulate, and we found that the rate of viability was close to about 74 to 75%, 74.8% to be exact. So we published this a few years ago. So coming to neck dissections in thyroid cancer, Dr. Ashok Shaha of Memorial Sloan Kettering Center in New York, he is still around with us. He still inspires us all. He's a champion of central neck dissection, and he is the man who has defined central neck, modified radical neck, and various recurrence patterns in thyroid surgery. So we've moved from the past gradually to the present today. Another person who is a champion of neck dissection in thyroid is Dr. Droll from Halle in Germany. So he championed compartment-oriented neck dissection, meaning that only those compartments where we found nodes were to be dissected and not the others. So when it comes to central neck, there's a fair amount of discussion and controversy today. What started off as a mandatory central neck dissection, which classically involves elimination of the fibrofatty tissue between either carotid artery laterally and from the thyroid cartilage to the suprasternal space, craniocaudally. So the whole thyroid space would be sort of skeletonized earlier. And then people found that the benefit was not too much and the risk of hypocalcemia was quite a lot. So thereby came the subject of laterality of central neck. So central neck was divided into right central neck and left central neck by the midline. So if it was a unilateral, if it was a single focus of cancer, many people advocate only the ipsilateral central neck to be dissected. And nowadays, we have even come to prophylactic versus therapeutic central neck. So if there's no preoperative evidence of central neck node involvement, such neck dissections are turned to be prophylactic. And there are many of them who even say that it's better to avoid central neck dissection altogether. So we are going from one extreme of radicality to another extreme of conservatism. That's a debate that rages on. It's a discussion. It's a lively discussion. However, if I kept my hand on my chest and if a patient came to me and said, "Doctor, I have cancer, please do something," I would be very, very brave not to do as radical a dissection as possible. So right now, what I would do would be a total thyroidectomy with at least an ipsilateral central neck dissection. So coming to nerve monitoring, which has come into our realm over the past decade, championed by Gregory Rudolph at Boston. So there are two ways of doing it: a continuous nerve monitor or an intermittent nerve monitor. It needs a special kind of an endotracheal tube with a pressure sensing electrode that is put across the vocal cords, and then we stimulate the nerve and we look for a contraction of the vocal cords. So this has been increasingly done, and centers with nerve monitoring have been on the rise lately. If available, best to use it, best to prevent the nerve injury from happening. So it brings us to the age of Storz. So we came from stone and we are now at Storz. Endoscopic thyroidectomy is a definite thing that's existing today. How much does it exist? Again, a matter of conjecture, a lot of debate. A few champions around with us today: Paolo Miccoli of Italy, Anku Nanowang of Bangkok, our own Dr. Amit Agarwal of SGPGI Lucknow. He was with SGPGI till recently. Now he's moved on to Medanta Hospitals Lucknow. So we employ predominantly two approaches: the Baba approach from below, going into entering the neck through the axillae and the breasts, and then we have the transoral transvestibular approach, which we move to move through from the gap between the gum and the mandible. We enter into the subplatysmal space directly, we create space, and for small nodules, these are acceptable procedures. Although it is certainly not without its risks, it has a very high, very steep learning curve, and the indications are very niche. It's not that we would advocate these procedures for everybody with a goiter. Somebody may be a prophylactic thyroidectomy or a small nodule, less than 2 centimeters, known to be malignant. Go ahead, do it if you're comfortable. But it's there. That's what I would like to say. So various parathyroid identification adjuncts have come into our realm today. It all started off with indocyanine green and the Firefly technology. We inject patients with indocyanine green dye, and then 15-20 minutes later, we look for fluorescence with the use of a particular wavelength. We initially started this off for biliary surgeries, and then we found that the parathyroid also takes this up. Although the efficacy and accuracy is probably about 65 to 70%, not ideal, but if it is there, use it. And then we found that the parathyroid is a tissue which gives rise to autofluorescence as well. So any tissue with a rich mitochondrial content will emit light by itself. And this has been found to be in the near infrared spectrum. And when we use a suitable light source, we can identify the viable parathyroid by virtue of its autofluorescence. So friends, so we have come all this way from the days of Charaka and Sushruta and Galaganda to the day of parathyroid identification adjuncts, minimal access thyroidectomy. I will not call it minimally invasive thyroidectomy. It is maximally invasive because the least invasion would be approach directly from above. However, there is a niche of patients for whom remote access thyroidectomy is suitable and who would not be averse to employing it as a approach. So we do use it for them. So we may be seeing afar, but we are all dwarfs on the shoulders of giants. And because we sit on the shoulders of giants, it is possible for us to see far. Thank you very much for listening. Again, thank the Karnataka State Chapter for this opportunity. And if there's any questions or comments, I would welcome them.
Yeah.
Moderators, please.
Yeah, it was an excellent talk, Dr. Himagirish, taking us right through the history of thyroid surgery. Yeah, if there are any questions from the audience.
The chat box says many things.
Yes, sir. I'm just trying to go through the chat box.
So till that time, just one or two things, Dr. Himagirish.
Yes,
so, very good presentation, number one. And see, it's very important that we need to know from the history that what we were doing and what we are doing. And obviously now proceed to the future. That is what it is, right?
Yes, sir.
So since one or two things have come here that I think I also would like to tell that I think the thyroid is one of the common things that every surgeon should know the basics to advances, correct?
Yes,
So
sir.
this is something, you know, which a general surgeon with the experience, which he is able to identify the nerves, parathyroids well. Of course, the modern gadgets may not be there. That, as you rightly mentioned, the indocyanine green and other things.
Right.
One or two things to question to you that when we were students, that they used to tell that, you know, that upper pole should be ligated
Yes.
close,
Yes.
and
Yes.
the lower pole should be away. And now that has changed the branches, etc.,
Yes,
etc.
sir. Yeah.
Right. So,
Yeah.
what is your techniques related to identification of these nerves? Because that is one thing which probably I know that this is a little beyond the topic, whatever you have been given history. But just quickly so that people will get benefit. Yeah, please.
So capsular dissection. As soon as we expose the thyroid, we incise the midline. If it's a big thyroid, we employ the lateral approach where we reflect the sternomastoid laterally and separate the internal jugular vein away from the goiter. That makes the thyroid dissection easier. And having done that, if required, divide the strap muscles, particularly the sternothyroid, and then approach the superior pedicle because that gives 80% of the blood supply. Once that is done, it is easy for us to retract the thyroid medially. And once that is done, we move on the capsule on the surface of the thyroid because whatever nerve is there, unless it's very much distorted, most of the time the nerve, invariably 99% nerve lies posteromedial to the goiter. So we pull the goiter medially and then we work on the capsule. Identification of parathyroids. Now parathyroids gives it a reddish color, the rich vascularity. It is the color of caramel. So it is the shape of a lymph node, the color of caramel. So we look for parathyroid, identify it, and then stay in front of the parathyroid and pull the gland away from the rest of the body. And try and avoid as much traction as possible. Try and meticulous dissection, careful dissection, delicate handling. This is what I would say at the moment.
Yeah, that's what how the things have changed. That concept, that history,
Yes.
like whatever we are talking.
Yes.
Don't see the nerve to know. Don't see the nerve. That's how it is.
So
Earlier,
in fact, if I want to take a minute, I would
yes,
refer
please,
to this. I would
please.
refer to this recurrent laryngeal nerve as a daughter, sir. I have a daughter, so we bring up our daughters with so much of care, and then ಬಹಳ ಕೇರ್ಫುಲ್ ಆಗಿ ನೋಡ್ಕೊಂಡು ಅವಳನ್ನ ಆಮೇಲೆ ಅವಳನ್ನ ವಿದಾಯಿ ಕೊಡ್ತೀವಿ, ಅವಳ ಗಂಡನ ಮನೆಗೆ ಅವ್ರ ಸಸುರಾಲ್ಗೆ ವಿದಾಯಿ ಕೊಡ್ತೀವಿ. So like a daughter sasural, the RLN sasural is the larynx. So identify the RLN and always keep the RLN in our sights till the point where it exits the neck into the larynx.
Definitely, because we know the value of the, as you rightly put it, Amylita gallic acid. This happened for her. There's one of the PG questions. Sometimes we ask, what is this nerve? Quiz question or something.
Yes.
This happened in India only. This whatever that she lost her voice. So when the goiters were there, she was operated actually. Anyway, that's a different thing. The one or two things is that yes, singers. So those who want to maintain that high pitch, high pitch, especially.
Yes. Yes.
So, and very often it is underrated. That's what I'm trying to tell.
Yes.
Because when we were there, so much was put on recurrent laryngeal nerve.
Right.
Over a period of time, only this little bit of aspirations, the change in the voice, all that things.
Yes.
And one more thing, whatever I have observed is that nerve preservation, correct. Again, parathyroid. Again, we are not actually, we have never been, it was just passing complications list is there, big, for the thyroidectomy complication.
Yes.
See, the supplementation of the calcium, and 2 tablets, sometimes 6 tablets, it's one, it is not all that, what I can call as a compatibility. They cause some constipation and other complications are there related to this calcium. So obviously the message is clear that we need to take care. Yeah, please, I think others, please continue.
I can see one question Dr. Sandeep Nayak has asked, how do you manage hypocalcemia postoperatively? If I can take a couple of minutes for that. Nowadays, world over, there are two concepts. One is the transient hypocalcemia. The other is permanent hypoparathyroidism. Now, transient hypocalcemia the worldwide, the prevalence is almost, sometimes it is 50%. So in fact, we've even stopped calling it a complication. It's a sequel. Because it is so common, every second or third thyroid surgery, total thyroidectomy patients have this. So the guidelines they no longer call it a complication. So what we do is we look at calcium. The nadir, it reaches the nadir on the second day of surgery. That is second post-op day. Do a calcium at that time, and if it goes below 8, then we have to give intravenous calcium.
I'm in the meeting. Call me after another.
Otherwise, we supplement the patients with oral calcium. The other thing that we found is we do this parathormone either intraoperatively or on the day of surgery, post-operative day 0 parathormone. And this is another thing that we've been doing, and we have data from about 60 to 70 cases that we have done till date. So the threshold is 11. So if the parathormone on the day of surgery is 11 or less, such patients might develop hypocalcemia later. If it is double digit, then such patients are safe.
Dr. Ravi Shankar,
Yes, sir.
please.
Yeah. There are a lot of I think it is a fascinating journey of the thyroid. I think I learned a lot from, though I thought I knew a lot of history. I learned a lot from Girish. The fascinating thing is that Halsted visited Langenbach, who was the pioneer surgeon in Germany, and the Theodor Cocker and Theodor Billroth are both his students. And he also pioneered the current residency school which is there both in Europe and in America. And Halstead, when he visited them, he took that across the pond to America. So the residency system that is there now is due to Langenbach, who also has given us a lot of things like Langenbach's the retractors, forceps, and also the first person to
Yes,
perform the open cholecystectomy.
right.
So a lot of things. So the illustrious teacher and then two illustrious pupils who contributed a great deal to thyroid surgery.
Right.
Himagirish,
Right.
have you used methylene blue for parathyroids?
We generally don't use methylene blue, sir.
It is documented one of the ways to.
Yes, sir. Yes, sir. It was initially started.
Yeah,
Then it is not very specific and it's quite a strong dye. So sometimes we can't identify our structures.
I know. You
Yeah.
need to use it selectively and
Yes.
diluted one, then
Yes.
possible.
Yes.
We have used and we have done few studies on this also.
Okay.
It works well, actually.
Okay. Okay.
It was excellent, Himagirish. Thank you.
Thank you very much, sir. Very much humbled by all your kind comments. Again, thanks for giving your time, and thanks for lending an ear.
Dr. Harsha, you want to tell anything? Dr. Harsha? Dr. Harsha?
Sir, nothing, sir. The question was as usual, because some postgraduates are participating
Yes.
as well as
Yes.
young surgeons are
Correct.
participating.
Correct.
So the way we lost so many surgical procedures, similarly, the training is not adequately given in MS time. Then PGs will not be, after becoming a consultant, he will not be able to do thyroid because thyroid is not a simple case.
Yes.
Definitely, my boss, Dr. Shivswamy sir, was used to tell, if you do thyroid, then you are just entering into general surgery. If you can able to do thyroid, if you can do a CBD exploration, then only you are a general surgeon. But nowadays, those two things nowadays gradually becoming medico legal in such a way that one fine day in another 20, 30 years, general surgeon peer group may say that general surgeons do not do thyroidectomy. Such thing. See, that's how the Bolam test will be decided. In that manner, I am still a bit worried that maybe our one or two generations thyroid will slip out from general surgeons basket. That's what I felt.
As an answer to that, if I wanted to answer that, it's not. We would not call people this and that. Anybody who is a student of any surgery, and anybody who approaches it with honesty and earnestness will certainly do
Correct.
well.
Correct.
There are so many of us general surgeons who get called to who get called as examiners for MCH examinations even today. There's no shortage of people with MCH degrees. So that is it's an apprehension that is unfounded. So if we actually follow it with passion, we'll be able to do justice to it and we'll be able to excel.
Sir,
Yes, sir.
without any prejudice to our ENT colleagues, that was the question. I still feel we as general surgeons, we are more exposed to thyroid and we do more amount of thyroid surgery than compared to ENT surgeons. I don't know what is your opinion about this.
It's the same. I mean, as in, I would repeat that, sir. Regardless of the degree, even if an MSENT people, if they approach thyroidectomy with all the seriousness and all the earnestness, and if they actually are very passionate about learning it, it is about identifying. It is about identifying the techniques and the principles of thyroidectomy. And anybody who is honest about that, we don't see any reason why they should not, do it. If the patient is benefited, if there's not much of risk, I don't see any reason why it should not be done. Because thyroid is something that is being done by general surgeons, by oncologists, by ENT. by endocrine
Yes, sir.
surgeons, a lot of people.
And of course, sir, adding on now, there is a MCH head and neck is separately is there.
Yes.
So MCH head. Anybody else wants to say one or two comments so that we can probably conclude, or anybody else?
Prashantappa sir has a point.
Sir,
Sir, namaskara. Yes.
namaskara,
Yes,
sir.
sir. Sir, yes.
Dr. Himagirish Rao. Yeah, it was really nice. You have covered everything. Like Ravi Shankar said, lot of information we got it from
Yes, sir.
your talk.
Thank you.
Other than doing surgery, the other aspects which most of us may not be knowing. It
I
was
think
it was
Prashantappa
really,
sir has
very
got a
nice.
lot of
Thank you.
material for his quiz.
Yeah.
Dr. Himagirish, I forgot to ask you one question. This
Yes, sir.
the keloids.
Can,
You know
can I,
that.
sir? Shall I? Can I, sir? Shall I complete?
Oh, sorry. Yes, because
Shall I complete, sir?
Please continue.
Yes,
Yes,
sir.
yes.
Yes, I'll take only 1 minute, sir. I'll complete, sir.
Yes.
Thank you, sir. Thank you, sir. Thank you, sir. Yeah, really, it depends on the number of cases under whom the candidate has been trained and how many cases he has seen, how many cases they have assisted the cases, and how many cases they could see during their tenure having complications in the form of both nerve injuries and parathyroid. Probably that will make a good surgeon in their future. So that's what is required during their training period. So with that, they will learn a lot. If they see a lot of complications, probably they will be scared to do thyroid surgery in their surgical life. If they have seen many good surgeries, good recovery, less complications, probably they will motivate them to do good surgeries. That's what I feel. So if they can get trained with good outcomes, probably that will motivate them to do good surgeries. This is what I have seen. Maybe a small information.
Absolutely.
Thank you, sir. Shenoy, sir. Thank you. Thank you, sir. Thank you.
Sir, you were about to make a point, Shenoy, sir.
Nothing that. See, long back, this was only information. I did not read this. That the blacks
Yes.
that have the largest tendency to the keloids in the neck.
Yes.
So thyroids for that, the exposure started from the actually below the mammary crease there by raising a flap up to the neck, and that's how that thyroidectomy was done in a few.
Okay.
So in other words, the exposure part, I'm just trying to think about that. So it is not necessarily from the neck; it can be from below. Whether that has also given the idea of the minimal access or whatever you can call it as different approaches. Just wanted to
certainly, sir.
Sir,
comment
but
on this.
Unfortunately, keloid tendencies are more common on the chest wall as opposed to the neck, I feel.
Correct. Definitely.
Now, what happens is when the scar that we put, that descends in time. With time, the scar descends. Wherever we put in the neck, it descends by about 1 to 2 centimeters. And that's why even as MS postgraduates, we are taught never to put an incision less than 2 finger breadths below the above the suprasternal notch. We put 2 of our fingers at the point when we are making an incision. So this is because after surgery, it sort of draws, and it's especially in females. It's the weight of the the body that draws the scar onto the sternum, and then that leads to hypertrophy. So that is a point that we follow.
Okay, so shall we? Anyone else? So,
sir, if with your permission, sir, there is a question from one of my PG students.
Yes, definitely.
Regarding drain, sir.
Yes.
The drain to no drain, any guidelines you would like to give Himagirish, sir?
I would probably not give any guidelines. Of course, it is amply.
Question has come from one of my postgraduate students.
Certainly. I'll address that. It's a good question. It's a very good question. So this subject of drains, it's been amply proved all over, and there's a lot of evidence saying that drains are not required. So it is that whatever hemostasis that we achieve at the end of surgery, most of the time that stays. And what we do is just before closing, we remove the shoulder bag. So we remove the hyperextension of the neck, and then we put some saline into the neck cavity, into the thyroid bed, and then we give Valsalva to the patient for about 15 to 20 seconds. So suppose there is some platelet plug which is blocking, which is not a very secure vein, that will come undone, and then it will start bleeding. So maybe once in probably 15, 20 times it happens. So this is why we check it. And if there's any bleeding at that time, we secure that vessel and then we close the neck. Depends on the amount of dissection and the type of goiter, the size of the goiter that the patient has, retrosternal, malignancy. So anything that is a large goiter, which is say involving the whole of the neck, or any malignancy that involves neck dissection, retrosternal goiter, these are all cases where there's a lot of dissection. More the dissection, more the seroma, more the lipolysis. So in such cases, it is safer to keep a drain. Probably may not be necessary, but if I keep a drain, I'm gonna sleep comfortably in the night. I'm not gonna lose my sleep worrying whether I have to go back and open the sutures in the middle of the ward. It's a feel thing. Evidence will tell you that drains are not required, but for large goiters, the bigger surgeries, it is not bad to keep a drain.
Girish, one question.
Yes,
Any
sir.
advantage for ultrasonic shears or ligashore shears?
Yes, sir. Yeah, certainly. We have used ultrasonic and ligashore shears, and it is called sutureless thyroidectomy. Of course, sutureless because we do not need ligatures for the pedicles, and we do that. We do that a lot. We use ultrasonic shears, and we need to ligate the pedicles at all. And it is as good, if not better, than conventional surgery. Better because it takes less time. It takes time to tie a ligature.
Excellent, Girish. It was really very
Thanks again. Thank you.
fascinating journey of thyroid surgery.
Sangamesh has asked whether it's suction drain or corrugated. Always suction. The only place where a corrugated drain is placed in an abscess. That is my sincere belief.
Himagirish, Dr. Shivram here.
Sir, namaskara, sir.
Excellent presentation. I
Thank you very
enjoyed
much.
the
Thank you, sir.
story, the way you narrated. Your English is excellent. I was just wondering.
Thank you,
Very
sir.
good. Excellent. Excellent.
Thank you. Thank you again.
Thanks for the presentation.
Thank you, Shivram.
One
Thank you,
more,
sir.
sir. What about bothering about recurrent laryngeal now?
Yeah.
Better to ligate branches rather than the pedicle. You will be
Yeah, that's
always
the
safe.
thing.
Even not
We do this.
recurrent laryngeal, even external laryngeal or superior laryngeal, you can
Yes.
wait.
So we
It may
like
take another half an hour extra or 15 to 20 minutes.
certainly.
Only
Meticulous dissection and capsular dissection, like getting the individual
yes,
branches
stick to the capsule of the thyroid.
onto the capsule.
And don't try to demonstrate the recurrent laryngeal unnecessary.
No, we have to. We have to demonstrate. We have to identify.
No, to convince the others, to show them that this is the recurrent laryngeal. For example, when you are teaching this one, try to dissect and show them.
As we dissect, they can see.
You have to identify as a surgeon, identify and keep quiet.
Yeah. Laser ablation of thyroid is not on the horizon yet. Microwave ablation, yes. Alcohol ablation of nodules, yes. Very much debatable. Sunil has asked the question. Nice question, Sunil. Microwave and alcohol ablation being done for very selected nodules, but the jury is still out as far as the complications are concerned. Best is to open and take it out. Subtotal abdominal thyroidectomy, your practice, sir. Subtotal thyroidectomy is a thing of the 20th century, as far as evidence goes today. Best is to do a total thyroidectomy.
I think there are only two thyroid surgeries, either a total lobectomy or a total thyroidectomy,
Yes.
TL or TT.
Yes.
Okay. Dr. Sarvesh.
We have to thank Rajgopal Shenoy sir for an excellent choice of that speaker and excellent topic as well.
Thank you.
Thank you again.
Yeah, it was an excellent journey of thyroid. You know, Himagirish, the
Yes,
journey
sir.
started and our chairman, Dr. Rajgopal Shenoy, had traveled to Bhutan.
Right. Oh, are you in Bhutan now, sir?
No. Today I come back actually.
Okay.
Today I am traveling from Tamil Nadu to Mysore.
Oh.
The travel, the journey of thyroid was so nice. I didn't even miss a single word of yours.
Right. Right.
The presentation
Nice.
was very nice.
Thank you. Thank you again. Thank you very much.
I thank our chairman, Dr. Rajgopal Shenoy, for arranging excellent things every month.
Thank you, sir. Thank you again.
Today we had only one speaker. Usually we used to have two speakers.
Right.
And when we discussed, he decided we'll have only one, not two.
Right.
Because thyroid is a very good subject which needs time.
Yes.
Thank you, sir. Chairman, sir.
Thank you.
Thank you.
I thank today's speaker, Dr. Himagirish K Rao, for his excellent journey of thyroid he presented. Thank you, sir.
Thank you again.
I thank our moderators, Dr. Shrishail Metgud and Dr. Harsha G.V.
Thank you, sir.
Thank you, sir.
Thank the immediate past chairman, Dr. Hepsur, Dr. immediate past secretary, Dr. N. Chandrasekhar, our past president and GC member, Dr. H.P. Shivaram, and Dr. Yalagachin, sir, GC member, and all our EC members who attended today's excellent talk on thyroid journey. I thank the chairman-elect, Dr. Naaz, and all EC members and all members who attended, including the PGs. Thank you all. Good night. Good night, sir.
Thank you.
Good night.